Imagine a healthy pregnant woman in labor, and within minutes she suddenly develops severe breathlessness, collapses, starts bleeding uncontrollably, and despite all the efforts, her life hangs in the balance. This rare but obstetric catastrophic emergency is known as amniotic fluid embolism, also known as AFE. So, this is a life threatening obstetric emergency and it is associated with very high maternal mortality rate, and the patient dies within 30 minutes. The mortality rate earlier was 80 to 90%, but now it has dropped with 30 to 50% with immediate and adequate interventions. Frequency of amniotic fluid embolism is 1 in 1 lakh pregnancies, and the case fatality is 11 to 43%. Now what happens that due to sudden gush of amniotic fluid, fetal cells, hair, amniotic debris entering into the maternal circulation, patient can develop certain signs and symptoms which can be sudden collapse due to profound hypotension, hypoxia or hypoxemia, DIC or disseminated intravascular coagulation. The cause can be obstetric causes, non-obstetric causes or anesthetic causes. Obstetric causes includes acute hemorrhage, amniotic fluid embolism. This is the differential diagnosis of this condition if patient is suddenly collapsing. So acute hemorrhage, amniotic fluid embolism, placental abruption, uterine rupture, uterine atony, eclampsia, postpartum, peripartum cardiomyopathy. While non-obstetric causes can be pulmonary embolism, air embolism, anaphylaxis, septic shock, intracerebral hemorrhage, drug toxicity and MI. Anesthetic causes can be high spinal anesthesia, aspiration, local anesthetic, toxicity. There can be certain factors which may be associated with the amniotic fluid embolism like advanced maternal age, multiparity, meconium stained liquor, obstructive labor, intrauterine death, polyhydramnios, tetanic uterine contractions, maternal history of allergy or atopy, uterine rupture, placenta accreta, trauma, diabetes and operative vaginal delivery, including operative deliveries like cesarean section. Another name for this condition is anaphylactoid syndrome of pregnancy. Exposure to maternal circulation to the amniotic fluid, fetal cells or debris may lead to hypoxemia, pulmonary vasoconstriction, cardiac failure and even death. And it also helps in the activation of complement cascade stimulating immunomediators and producing a reaction just like anaphylaxis. So amniotic fluid also have a procoagulant tissue factor. So this condition can occur in two phases, phase 1 and phase 2. Phase 1 where biochemical are released after the entry of the amniotic fluid, and this leads to pulmonary artery vasospasm or vasoconstriction, then pulmonary hypertension, right ventricular pressure increases and there is right ventricular dysfunction. This phase lasts for around 30 minutes, and in the phase 2 right ventricular dysfunction leads to left ventricular failure, and this can cause pulmonary edema or DIC, and DIC can cause passive hemorrhage, etc. Now there are certain signs and symptoms through which patient can present. So the symptoms include dyspnea, cough, headache, chest pain, while the signs include hypotension, there will be fetal distress, pulmonary edema or ARDS, cyanosis, coagulopathy, seizures, bronchospasm, cardiopulmonary arrest and uterine atony. The treatment is the diagnosis of exclusion after ruling out the other causes of sudden intrapartum collapse, and the management is symptomatic and supportive because there is hypoxia, so we have to maintain the oxygenation, hemodynamic support and correction of coagulopathy. Immediate resuscitation, airway breathing and circulation is maintained. 100% oxygen is given by non-rebreathing reservoir face mask. Properly assess the patient, control of the airway, ventilation of the lungs with tracheal intubation may be needed. While for securing the circulation, 2 large bore IV lines, green or pink, are secured and send the blood for coagulation profile, CBC, cross match and arrange blood products. Left atrial manual uterine replacement can be done, and hemodynamic support to reduce the preload and vasopressors can be given. Fluid resuscitation is with crystalloid or colloid to optimize the filling, and inotropes can be given to maintain a BP because there is hypotension. Arterial line for continuous blood pressure monitoring is very essential, and we have simultaneously we have to monitor the fetus, and early consideration of delivery of the baby is given. Uterine tone should be assessed, and if needed uterotonics can be given. Coagulation should be checked, and recombinant factor 7 may be used. Use of plasma, cryoprecipitate and platelets is as advised, and antifibrinolytic agents like aminocaproic acid Trenexa may be helpful. Now, what investigation will you look for? So, in coagulation profile, there can be associated DNC in 80% of the cases, so coagulation profile will be deranged, and because this is amniotic fluid embolism leading to right heart failure, then left heart failure, so there may be signs of heart failure or right ventricular strain in the electrocardiogram. So there can be tachycardia, ST segment T wave changes which are consistent with the right ventricular strain. ABG should be done, and the ABG changes are consistent with hypoxia. Because partial pressure of oxygen in the arteries will be on the lesser side. Chest X-ray can demonstrate pulmonary edema signs. Echocardiography can be done, and serum tryptase enzyme can also be investigated. Now, the management is this patient is monitored in the ICU, and one should be aware that there is high risk of developing ARDS, heart failure and DIC. Supportive treatment with ventilation, inotropic support, hematological support and steroids can also be given. Now, potential interventions in severe life-threatening cases of AFE are inhaled nitric oxide for pulmonary hypertension leading to right heart failure, and extracorporeal membranous oxygenation for severe hypoxia and left heart failure can be considered. So, the pathogenesis is that whenever there is breach in the amniotic membrane and simultaneous breach in the uterine venous channel, so both breaches are there. Amniotic फ्लूइड का जो मेम्ब्रेन है उसमें भी ब्रीच है, और आपका जो यूट्राइन वेसल्स है उसमें भी ब्रीच है. तो इसकी वजह से क्या होता है, जो एमनियोटिक फ्लूइड होता है वो लीक आउट करके कहाँ आ जाएगा, आपका यूट्राइन वेस्कुलेचर में आ जाएगा. एंड दिस अलाउज द एमनियोटिक फ्लूइड विद पार्टिकुलेट मैटर. पार्टिकुलेट मैटर इज fetal debris, fetal cells, amniotic meconium stained liquor, and this enters into the maternal circulation, and then through IVC, through this uterine artery, it goes into the anterior branch of the internal iliac artery, the internal iliac vein, then from internal iliac vein it goes into the inferior vena cava, then right atrium, then lungs of the mother, and after lungs of the mother it goes into the left atrium and left ventricle and into the rest of the circulation. So this is the pathophysiology. And there are two hypotheses. First hypothesis tells that whenever amniotic fluid enters, this contains tissue thromboplastin, which is a coagulation factor as we have studied in tissue factors. These activates the factor 7 and 10 and leads to DIC or disseminated intravascular coagulation, while amniotic fluid enters the maternal circulation, and due to SIRS, that is severe inflammatory response syndrome, there is vasoconstriction and hypertension leading to pulmonary edema, acute cor pulmonale, which leads to left heart failure. So this is the thing, and the criteria is that the clinical onset during labor or within 30 minutes of placental delivery. So it can also occur in cesarean section. Hence, the first diagnostic criteria is that clinical onset during labor or within 30 minutes of placental delivery, abrupt onset of cardiopulmonary arrest, or both hypotension and respiratory compromise. So patient just after delivery can within 30 minutes of placental delivery can complain of having respiratory compromise, respiratory decompensation is occurring, patient is having lower BP, cardiopulmonary arrest or cardiorespiratory arrest is occurring, and when you check the labs there is over DIC but there is no fever. So this is the criteria for the management. And autopsy on after death of the patient, because most of the patient can land into mortality. So amniotic fluid embolism and diagnosis of exclusion, and for definitive diagnosis, autopsy of the maternal lungs where amniotic fluid is extracted is very important. So this is amniotic fluid embolism. Thank you.